All right, now we can utilize this information to calculate the osmolar gap. All right, you can estimate osmolarity or osmolality by doing this. 2 times sodium plus glucose over 18 plus blood urea nitrogen over 2.8. All right, now what we're doing is we are estimating a patient's osmolarity. We are estimating a patient's osmolarity. Now, normal osmolarity is what? What's normal osmolarity about? What is it about? Rough. Give me a rough number. 290, very good. 285 to 290. That's normal plasma osmolarity. Now, what we can do is we can estimate it using this formula. All right, now let me give you an inside tip on this formula. Change 18 to 20, change 2.8 to 3, and then you can do the calculation in your head. Okay, and it'll be close enough. You only have to be that close. You only have to be that close. All right, so let's put in our normal numbers from our BMP. Sodium is 140, glucose is 80, blood urea nitrogen is 15. So 2 times 140 gives me 280. 80 divided by 20 is 4. 15 divided by 3 is 5. That comes out to 289. If you actually punched it out on the calculator, what would you get? 290. 289, 290. It's all good. It's all okay. It's no problem. Close enough. Which is close, you know, and if you ever forget the normal plasma osmolarity or osmolality, use the osmolar gap equation to calculate it, and it'll remind you. It'll remind you. All right, now what this is an estimate. So I take the patient's sodium, glucose, blood urea, nitrogen. Don't use the norms. Use the patient's data. Patient X on the clinical vignette, step 1. They have plasma sodium of X. They have a glucose of Y. They have a blood urea nitrogen of Z. You use those numbers. You double their sodium. You take their glucose divided by 20. You take their BUN divided by 3. Now, what you're doing with that is you're estimating the plasma osmolality. You then compare it to what's measured. And that's where we get the osmolar gap. It's the difference in what you estimate from a patient's data and what's measured from a patient's data, or from the patient itself, from the blood, from the plasma. You can measure osmolality. All right? Measured should not be more than 15. And we did forget to put in the 15 in the book, so please pin in the 15. So the idea is, if I estimate it to be 290, then I'm expecting the measured to be 305 or less. They should be within 15. All right, what if they're not? If they're not, you will be given the measured. Yes, you have to be given the measured. There's no way for you to derive the measured other than them to just flat give it to you. They have to give it to you. All right, I look at those two numbers. I see how close they are. If the measured is well above 15 from what you estimate, then you have a significant osmolar gap. Some of the things that can cause that: ethanol, methanol, ethylene glycol, acetone, mannitol. All of those are potentially ones that can make it go up. All right, clinical vignette for you, step 1. Clinical vignette for you, step 1. 55-year-old male enters the emergency room. He's walking a little funny, kind of leaning on one side like this, and he's kind of slurring his mouth. He's talking kind of like this, and so you're thinking, wait a minute, 55, he might be having a stroke. Yeah, man, Al, he might be having a stroke. That is a reasonable thing to put on your differential diagnosis. That is reasonable. Okay, then you get the patient's data. You estimate their osmolality to be 291. Well, the lab comes back and it says the osmolality is 450. So you estimate 291 from the patient. They measure it, it's 450. You have an elevated osmolar gap. Are we going to pick stroke? If that's one of the answers, are we going to pick stroke? Nope, stroke's off the table. Yeah, what's wrong with my patient? Hey, maybe they had a little too much ethanol.